Good evening, friends, colleagues, and anyone else that happens to have strayed into the presentation. And welcome to this evening's BOFAS Virtual Journal Club, which is entitled Weights and Extraneous Measures, Issues on the Perioperative Management of Ankle Fractures. We'll have a slight deviation from our normal presentation style tonight. There will be two halves still. The first half will consist of discussion of Chris Bretherton's WAX trial from the Lancet earlier this year, which will be presented by a senior fellow, Alex Beer. Then we'll have a reflection from Chris Bretherton and then take questions from the virtual floor. So please do add your questions to the chat. The second half will be slightly different in that there are essentially two papers, one from Mohammed Farhan Ali's unit discussing the use of tourniquet in ankle fractures, and a second paper on the same topic from Matt Costa, also on the use of tourniquets. That'll be chaired by my co-host Nijil Vasukutty. Again, we'll have a presentation summarizing the two papers, and then we'll have reflection by the two senior authors, and finally questions from the floor. We should be able to wrap up in an hour's time, about 9 o'clock. Before we begin, I'd of course like to thank very much the two fellows who have prepared the presentations, Alexander Beer and also Faizan Arshad. And also the senior authors who've taken the trouble to join us this evening, Chris Bretherton, Mohammed Farhan Ali, and Matt Costa. I'd also like to thank Karen Malhotra, who as usual is holding the reins and keeping the IT ticking us all over. So one other housekeeping announcement, by the way, which is that to obtain your certificates and feedback forms, there'll be a link posted in the chat, so please complete that, and it should all happen quite swiftly for you. So without further ado, we'll move on to the first paper, which is written, or the senior author is Chris Bretherton, who undertook his academic training amongst the dreaming spires of Oxford, and then transplanted himself to Queen Mary's and the London in the East End of London, where the spires are perhaps not quite as dreamy as in Oxford, but I'm sure it's a wonderful and gritty place to do trauma. Chris is a senior lecturer in trauma and orthopedics, and he has a particular interest in multi-center audit, randomized controlled trials, and priority setting partnerships, or so he tells me. You probably may know him as the past BOTA academic representative, a post which he denies getting because he could drink everyone else under the table. And he is the current Royal College of Surgeons BOA Associate Surgical Specialty Lead for adult trauma. He tells me that he spends a lot of time hanging out at #collaboration. Apparently this has nothing to do with occupied France and the Vichy regime, but rather to do with academic studies. So moving on, thank you, Chris. And I'd like to have the first presentation, please, from Alexander Beer on early versus delayed weight bearing following operative treatment of ankle fractures, the WAX study. Thank you.
Good evening. My name is Alexander Beer. I'm an orthopedic registrar with an interest in foot and ankle surgery. I'm currently working in Leeds Teaching Hospitals as part of the Yorkshire rotation. I'd like to thank BOFAS for inviting me to present a journal this evening, and the journal I'm presenting is the following one. It's early versus delayed weight bearing following operatively treated ankle fractures. It's the WAX study. It was a non-inferiority, multi-centered randomized controlled trial. The study was published in the Lancet in June 2024, and the first author, Christopher Bretherton, and senior author, Professor Griffin, are associated with Queen Mary's University Bone and Joint Health and the Royal London Hospital, part of NHS Barts Trust. The background of the study is that ankle fractures are very common, as we know. There's approximately 190 ankle fractures a day in the UK, most of which are treated non-surgically, but those that are treated surgically, there's a lack of consensus on post-operative weight-bearing restriction. Historically, surgeons would restrict a patient for 6 weeks due to fear of loss of position and malunion, but there is a growing trend towards early mobilization at 2 weeks, possibly this could reduce blood clots, it may improve functional outcomes, but there's currently a lack of evidence behind this. The existing evidence that we do have consists of a Cochrane review in 2010, which reported that there is insufficient evidence to support or guide weight bearing. The literature review performed as part of this study demonstrated that there are some more recent studies which demonstrate favouring early weight bearing, but there's a small sample size, and these studies had limited design. There was no large randomised controlled trials. NICE concluded that the current evidence had a high risk of bias and was insufficient to guide clinical decision making. So the aim of this study was to determine the clinical and cost effectiveness of early weight bearing at 2 weeks post-operatively compared with delayed weight bearing at 6 weeks post-operatively for adults after ankle fracture surgery. The methodology of the study, so the WAX trial was a pragmatic, non-inferiority, multi-centre randomised controlled trial across 23 UK hospitals. It was conducted by the Oxford Clinical Trials Unit, and in order to be included in the study, you had to be 18 years or older, you had to have your surgery within 2 weeks of your injury, and they intentionally included more complex injuries such as open fractures, osteoporotic fractures and syndesmotic injuries to try and make it applicable to a broader range of patients. The exclusion criteria included being treated with a hindfoot nail, having sensory loss or neuropathy, being unable to consent, or if your surgeon gave strict non-weight bearing instructions. Patients were randomized into 2 groups, early weight bearing and delayed weight bearing, using computer randomization. The study was not blinded, as both patient and clinician needed to know when the patient needed to start weight bearing. In the early group, at 2 weeks, the patient was changed either into a weight bearing cast or into a walking boot, depending on the unit's preference. And in the delayed weight bearing group, they were not weight bearing until 6 weeks post-operatively. They were very specific on their patient instructions, and patients were well supported. They all had a information leaflet. They all got weekly emails and text messages to give them advice on when to start weight bearing. And all the units were sent a voice recorder to try and record the patient instructions in clinic to make sure this was done universally from one unit to another. Outcomes. So the primary outcome measure was the OMAS score, which is the Ollerud and Molander ankle score. It's a validated and reliable PROM score in foot and ankle surgery. The minimal clinical difference, which is thought to be significant, is a score of 10 between the groups. That's for reference about the difference of a patient needing a crutch or not needing a crutch. The secondary outcomes were the quality of life score, EQ5D, and the return to work score, WPAI. In terms of statistics, they looked at the largest study, which had used the OMAS score to help them determine the following, and the standard deviation of 21.1 was used and an inferiority margin of -6 was chosen. They did a power calculation and sample size, and it was determined they needed 436 patients, and they also looked at significance and determined a cutoff of 5%. In patient recruitment, so 228 patients were screened for eligibility, and around about 1,400 were initially excluded. 164 had not had surgery within 2 weeks, and the largest group, 938, were excluded because the surgeon had strictly said they had to be non-weight bearing. 315 patients were unable to consent. In terms of results, 561 patients were therefore recruited, and 280 in the early weight bearing, 281 in delayed weight bearing. They had a median age of 50, 64% were female, and the other baseline characteristics were all very similar. The primary outcome, OMAS score at 6 weeks and 4 months in early weight bearing group was statistically significantly better, 4.42 points higher, with a p-score of 0.06. However, at 12 months, there was no significant difference between the groups. It's important to note this is below the minimally clinically important difference, which is thought to be 10. The complication rates were similar between groups, 16% in the early weight bearing, 14% in the late weight bearing. And we'll go into that in slightly more detail in a second. And the 12-month mean cost to the NHS. So they did a cost analysis. It was £725 in early weight bearing and £785 in delayed weight bearing. Cost saving of £60 therefore. And societal costing, taking into account work losses, saved £722 in the early weight bearing group. However, it had broad confidence intervals. Again, as I mentioned, looking slightly more into complications, whilst there was no significant difference statistically between the two groups, there were slightly more surgical site infections, 15 versus 12 in early weight bearing, 7 in early weight bearing versus 5 in delayed of wound dehiscence, and 4 failed fixations in early weight bearing versus only 1 in delayed weight bearing. However, none of the patients in the early weight bearing got complex regional pain syndrome, and 4 patients in delayed weight bearing got complex regional pain syndrome. In conclusion, this study found that early weight bearing was not inferior to delayed weight bearing concerning their primary outcome, the OMAS score. They had similar complication rates between the two groups, which were not statistically different, and early weight bearing was more cost effective than delayed weight bearing, which is also a significant finding. Early weight bearing is therefore a viable and potentially preferable strategy to delayed weight bearing. Analysing the strengths and limitations. So I think the main strengths of this trial was that they had very large numbers of patients, almost double that of previous studies. It was a very robust study design, which was well considered and well carried out, it being a randomised controlled trial. It included a wide range of patients. So 28% of the patients were over 60, 25% were trimalleolar, 30% needed syndesmosis fixation. So it clearly included a broad heterogeneous group of these patients, both complex and simple, which probably reflects what we're seeing in our clinics, and therefore makes this easily applicable to most of our daily practice. In terms of limitations, I think the main one is that 42% of the patients, or 938, were excluded due to surgeon weight-bearing instructions. Probably because they felt that the fixation was not stable, they were at risk of losing position and malunion. But it obviously limits how much we can apply this study, broad brush, to all of our patients in that case. 14% of patients... there's a 14% attrition rate in primary outcome, and only 9 of the 23 centres recorded audio instructions to patients and returned them to the study. I think it probably would be better to have a longer follow-up to look at degenerative changes in the long-term rate of arthritis, etc. And in the delayed weight-bearing group, 32% of patients, about a third, didn't follow the instructions and started weight-bearing earlier, within 3 weeks post-operatively. The rebuttal to this in the paper, which I think is valid, is that we can't control what patients do. We can only control what we tell them. And this study is doing a comparison of patient instructions, so if we tell them to weight bear or not. So yeah, I think that's a reasonable argument against this. So in conclusion, the WAX trial is a well-conducted study which has useful implications for clinical practice. While there are some limitations, the findings provide evidence that could shift the standard of care towards early weight bearing after ankle fracture surgery. Many thanks for listening to this presentation. I hope it provided a useful summary, and thanks again for BOFAS for asking me to present this paper today.
Okay, well, thanks, Zander, for a very concise summary of the paper. So before I invite Chris to start to reflect with us, I just remind everyone that you're more than welcome to submit questions to the senior authors. There is no question too foolish. We're all friends here, well, more or less. And do please put them on the chat if you have anything you wish to put to our senior panel. So, Chris, clearly a mighty piece of work on a very important topic. I'd like to share your thoughts on it with us first. So you have the floor. Please, things you felt were good about the study, things you might have done differently, and of course your general thoughts on the message, although I think we probably all know what your thoughts on the message are. But please reflect now for us. Thank you.
Hi, yeah, thanks very much. So yeah, thanks very much for presenting that. That was nice to hear someone else talk about it for once. And I think you've got all the sort of key points there and messages, the limitations and the strengths. Obviously, the strengths are it's a sort of big randomised clinical trial in 23 centres, which is many more than any other sort of study in this area. It had very few exclusion criteria, and that really comes into also the limitation that was discussed in terms of these, and that's what the question that always comes up in that little screening diagram. There were a high proportion of patients that were not included because they because surgeons said, you know what, I don't want to put this patient in the trial because I'm just not sure that they should be early weight bearing. And the reality is that when we looked at the number of sites that sort of went in, you generally had a pattern. You had a pattern in hospitals where surgeons just put every single patient into the trial. And then there was another pattern where basically there was 1 out of 10 consultants in that hospital that was interested in the trial and wanted to put patients in, and basically 1 to 10% of those patients went in. So that's really what explains that sort of screening diagram. But what I sort of say to people is that in terms of who actually went in the trial in the end, it was very reflective of the UK population in terms of the age, the demographics, the type of fractures, the percent that were trimalleolar, the percent that was syndesmotic. So in terms of how it informs my practice, I'm pretty happy that I'm like, that all works for me. Perhaps the patients in this trial were slightly younger. The mean age was this was 48 compared to 50 in a normal UK population, and so I think it's all good for my regular practice. And the default strategy is if you fix an ankle and you're pretty happy with it, then let them weight bear. So that's the sort of message that I'd take home. And then you then have to look at those complication rates. And again, this is something that I look at. There was a slightly higher risk of wound problems and the need for sort of revision surgery by 1 or 2%. Now that wasn't anywhere near to being statistically significant, but it's still something you've got to think about. And what I would encourage you to do. So just yesterday, we actually did an update to the Cochrane systematic review on this topic, and that was published yesterday. And if you want to go through and have a look, there's a table in there that looks at all the complications in all the pooled studies of ankle fractures. Basically, all the studies in that review say ankle fracture is good, it's fine, gives you better function or non-inferior function. But it just shows you the complications. And actually, in many other trials, they favour they non-weight bearing gave you more reoperations. That was my other reflection. And I guess the other reflection is, what would you do differently in the trial? And I think I'm not sure there is a great deal you do differently. I've mentioned about that exclusion criteria, why it's pragmatic and why I think that was important and why that still worked. And the other thing is about those patients that didn't follow their instructions and were non-compliers to their delayed weight bearing, i.e. they started weight bearing sooner than we told them to. And I can't really think of a way around that. We did explore sort of putting sensors in shoes. We couldn't really do that at the time. Maybe that's possible now. But what do you get then? If you then find that patients the sensors showed they were weight bearing when they said they weren't, how do you analyze that? Are those protocol deviations? How do you find compliance? So I don't think that really changes it. The only thing is whether you can give them a little electric shock if they start to weight bear to stop them weight bearing, but that might have some ethical issues. So I think happy with how the study went, and I'm looking forward to sort of seeing if you've got any other questions or thoughts about the study or how you might apply it to your practice.
Chris, thank you very much for sharing that. Slightly facetiously, I'm tempted to suspect that nowadays you can probably monitor who's weight bearing and who isn't with some sort of app. If you can have an app in Kiev that tells you where the missiles are going to strike and when they're going to come on your phone, then I suppose weight bearing in patients is small beer. But I entirely accept the very pragmatic nature of your study. At the end of the day, none of us know really whether our patients weight bear or not, unless you study the underside of the boot or something like that, and even that's a bit dubious. So I think that's a very reasonable, pragmatic approach to a common problem we all face. There's one question I have from Yanis Papachristos, which you've sort of half addressed. How can we put all operated ankle fractures in the same bag and draw a recommendation for early weight bearing at 2 weeks post-op? Only the surgeon knows how happy he is with his fixation and confident to early weight bear.
Yeah, so I think you've. I think since I published this study and came back, I probably fixed about 12 ankles, and one of them I didn't let them early weight bear because I was worried, and So that's just how it is. So I mean, and so the way I'm interpreting it is, and the way about the people that I've talked to, the surgeons that put patients into this trial, it was people that you fix them and you're happy and the bones come together. Not necessarily every screw is holding fantastically, but things fit together. They don't seem to be moving around. You're not sort of you haven't gone at a 4-hour tourniquet time trying to fix something, all sorts of stuff. So, and again, the same when we did the systematic review. When we looked at the previous papers, ultimately it's a patient, a surgeon, an ankle that you've taken from being unstable to stable, and you're pretty happy with it. Is what I think this reflects to. When you actually look, because although we did include patients with open fractures and whatnot, it was only about 4 patients of the whole study that actually had open fractures, right? Quite a high proportion. I think it was about 40 had X fixes before, so there were still these high energy ones. But ultimately, it's if you've got a patient that you're happy with, then weight bear them. In the patient where you're not happy, then I'm not sure I can necessarily like I say, I still non-weight bear some people if I'm just not happy.
Fine. So is it fair to summarize the message of the paper as in those patients who you think it is a reasonable prospect to bear weight early, that group will do as well or perhaps better with early weight bearing than in the ones you are particularly worried about for whatever reason?
Yeah. I mean, the assumption is that they do better, and they do slightly better. And if you look at the, I haven't spoken to a statistician about this, so I might get in trouble. But I think the sort of intention to treat so they're having like an unplanned return to theatre. It's something like the number needed to treat was 50. So basically, if you're going to deny 50 patients slightly better, function and generally better convenience to save you one reoperation, is that right? For me, yeah, probably not. For me, maybe what my number would be like maybe 1 in 20. But when 1 in 15 number needed to treat, it wouldn't be justified for me.
Okay, fine, thank you. We have a question from Mr. Beer, whose presentation we just heard. If there is a wound issue at 2 weeks, would you then delay weight bearing until the wound is healed, or do you crack on regardless?
So I can't tell you from the study. I can't give you any evidence from this paper really about that because we didn't really look into that. But if I look at my own work, not my own work, if I look at other people's work, but I did do a systematic review as part of my PhD, looking at some other papers, and it will go to sort of Matt's asked a question about the systematic review for orthotics and casts as well. So I'll mention that while I'm there in the same package. So the systematic review shows that the Cochrane review shows a cast versus a boot. A boot is just fine, and you get slightly better function if you put people in boots at 2 weeks after their ankle fracture's fixed, and you don't seem to get any increase in complications. So that's the sort of message from the Cochrane review to sort of put that one to bed. Basically, if you're happy enough with your fixation, put them in a boot and get them really weight bearing. Again, now you've got issues, right? So now you've got concerns about the wound, or you're concerned about the fixation. So I did a sort of in-depth analysis of one of the main paper that looked at casts versus boots, and when I sort of actually split up some of the complications, I actually found there really was quite a higher risk of wound complications in patients that had surgery in the trial that compared boots versus plasters. So for me, based on the evidence I've looked at, I would be more inclined to sort of stop them moving. I might say, so basically what I'm saying is I think that early movement, if you've got a wound issue, is probably more harmful than early weight bearing. So what I'd do is I'd probably restrict them. If they had a wound issue, I'd restrict them moving the ankle, but I'd probably let them weight bear still, would be my opinion. But it's only loosely evidence based, that.
Okay, thank you. Another question from Shivashankar Aithal. Was there a correlation between the severity of the fracture and the complications of wound healing / infection in the early weight bearing group?
No, I don't. The answer is I don't know. I don't know. I haven't looked at that different types of fractures and severity of fracture and whether that changed the result, and it didn't. But no, not that specific one correlation, I'm afraid. Sorry.
Okay. No problem at all. Thank you for your honesty. One question. It's very interesting that the large exclusion group, the 980 odd that were excluded by surgeon instruction. I was very curious to hear your comment that was essentially unit-based or perhaps cultural rather than correlating to fracture particularly. I suppose that begs the question, doesn't it? Which is, should you be out there banging the drum even more for this? And secondarily, would it be worth exploring with those surgeons why they made those decisions, what their preference was, why it could vary so much between hospital A and hospital B?
Oh well, there is a paper hopefully being published very soon on that, so I'll make sure I tweet that. So yeah, we did do interviews with these surgeons and healthcare professionals, and a lot of the issues were one of the issues that when I interviewed those people, often they were like advocates of early weight bearing. They were the early weight bearing champions. But some of them that weren't, some of the surgeons had medical legal issues, medical legal concerns. Again, just cultural issues about there's been a problem. You fixed it. It was early weight bearing. There was a problem. You're the only one in our unit that does that. Oh, you're an idiot. So that's the main reason really. So and it's all about. I mean, in this paper, we also discuss about what actually changes people's opinions and their views. So, if it is medical legal concerns, for instance, and that cultural issue, you've now got a randomised control trial published in the Lancet that tells you it's fine. You've got a Cochrane review just come out that says it's fine. So, if you're standing up in court, you've got some good. I'll come and protect you. But no, you've got some good papers now to say, hey, look, these are the good papers in the best journals saying this is safe. And then, maybe a bit more drum banging.
Thanks. Well, I mean, what changes people's opinion in practice is obviously the BOFAS Virtual Journal Club. I mean, what else would one go back to? On that subject, I suppose really what you're saying is we react, as we all know, as much to our own experience rather than to logic and evidence. But one question about the study. If you had time again, would you run it with a longer follow-up, or would it be worth a 12-month follow-up? Do you think the difference of early weight bearing will show a difference at 12 months? I'm asking you to speculate, I suppose. But
yeah, well, I'll give you the truthful answer first, and then the waffly answer. The truthful answer is no, because we got it into the specific small funding pot, which only let us do 12 months follow-up. And had we gone for a bigger funder, we probably wouldn't have done it, and we'd never have got the result. So that's the answer. That's the truthful answer. And then the more speculative answer is yes. It's good to sort of. It would be great to know that 2 or 5 year follow-ups. We are harvesting X-rays, which has taken a hugely long time, and we will be looking to see if there is any suggestion. We've got X-rays up to 1 year. Whether there's any early signs of arthritis in either group. So yeah, it'd be great to have other follow-up. And I think Shivanska's mentioned something about if there's no difference at 12 months, does it really matter when weight bearing is started? So I guess you could say no, but it's just about patient convenience, if nonetheless, because all these scores we measure at sort of 6 or 4 months, even if they're a difference. But you just realise, and I did lots of qualitative interviews, and it's just a nightmare hopping around on crutches, injecting yourself with extra dilated power, and people can get really. A couple of patients got really seriously depressed being non-weight bearing. So if it's just for that, I say 1 in 50 patients that you might think get a problem, I don't think it's justifiable to make people non-weight bearing when it can be a real misery.
Chris, thank you very much. I'm afraid it's time that we draw the first half of the evening to a close. Before I hand over to my colleague Nijil Vasukutty to chair the second half, there's a very poignant personal point made by Matt Costa, who tells us that from his own personal experience, he's deeply scarred by being non-weight bearing. It's utterly miserable. And also, you can't carry more than 1 pint, which is obviously life-changing and crippling. Matt, we will be offering counselling for this after the session. Nijil, thank you very much. Please take over the second half.
Thank you. Thank you, James, and thank you, speakers. Thanks, Karen, again, for running the show. Now, we move on to another topical perioperative issue, that is the use of tourniquets in lower limb trauma surgery. So there has been a lot of discussion and papers around the use of tourniquet for knee replacement. Now, we are looking at the use of tourniquet in lower limb trauma surgery. So we are discussing a systematic review from Mohammed Farhan Alani. This is from the European Journal of Orthopedic Surgery and Trauma. So it's titled Risk Associated with the Tourniquet Use in Lower Limb Trauma Surgery. So this is being presented by Mr. Faizan Arshad. After this, we'll also discuss Matt Costa's annotation in the BJJ from 2021 around the same topic. Just briefly about our two guest authors. Professor Matt Costa does not need any introduction. He is a professor of orthopedic trauma at University of Oxford and an honorary consultant trauma surgeon. He's more known for as being the chief investigator for a lot of national trials, national RCTs, and his special interest is the cost effectiveness of MSK trauma interventions. Our first author for the systematic review is Mohammed, who's a orthopedic registrar on the Warwick rotation, and he's a NIHR-funded PhD candidate with his main interest around the use of tourniquets. So I'll hand you over to our presenter, Faizan.
And thank you to BOFAS for giving me an opportunity to present at the Virtual Journal Club this September. My name is Faizan Arshad, and I'm currently ST6 registrar in the foot and ankle rotation at University Hospitals Birmingham. This evening, I'm going to be talking about tourniquet use in ankle fracture fixation. In this presentation, I will review and summarize two key articles. The first is an editorial published in the Bone and Joint Journal in 2021, led by Matt Costa. This article provides a narrative review of the available literature on the use of tourniquets, as well as findings from a survey that reflects current lower limb trauma practices within the UK. The second article is a systematic review and meta-analysis published in 2021. It reports the findings of 6 randomized control trials and analyzes some of the outcomes from these studies. The first author in both these papers is, of course, my friend and colleague from the Coventry and Warwickshire rotation, Mo Alani. Alex Trumpeter is also an author on both these papers. We will focus on the editorial first. So tourniquets have a long history, dating back to over 2,000 years when they were used in amputations, often just bands of cloth tied around the thigh. Today, we use thigh tourniquets in surgeries like ankle fracture fixation for several reasons. We justify their use because we claim that they help us limit intraoperative blood loss, improve the surgeon's view of the operating field, and that they can shorten surgical time. But has the use of tourniquets become so ingrained in our surgical culture that we continue to use them simply because it's what we've always done? As Mark Twain famously said, the less there is to justify a traditional custom, the harder it is to get rid of it. In 2020, a survey was conducted among 77 surgeons at the Orthopedic Trauma Society conference, and the results provide some insight into the current practices in the UK. According to the survey, 78% of the respondents preferred to use a tourniquet during these procedures in lower limb fracture fixation surgery. The most common reason were to reduce blood loss in 65% of surgeons and to improve visualization of structures in 32% of surgeons. However, while the survey gives us some interesting data, it's important to recognize its limitations. For one, we don't have information on the level or grade of the surgeons who participated. We don't know whether they were trauma surgeons or specialists in foot and ankle surgery. Also, there's no clarity on the surgical settings these surgeons were working in, which could have an effect on their preferences. Another critical point is that the survey doesn't specify how the questions were framed, so this could potentially skew the results. In their article, Mr. Alani and Mr. Costa explore the known effects and concerns surrounding the use of tourniquets during the surgery. While tourniquets are widely used, studies have shown that they come with significant risks. These include an increased likelihood of post-operative pain, as well as skin injuries, venous thromboembolism, neurovascular injuries, and infection. Additionally, tourniquet use has been associated with poorer functional outcomes and longer hospital stays. A major concern is the reperfusion injury that can occur when tourniquet is deflated at the end of surgery. This sudden return of blood flow can lead to swelling and increase the risk of complications like compartment syndrome. Beyond the local effects, there are systemic concerns as well, such as change in heart rate, blood pressure, and even increased intracranial pressure, which may cause microemboli in the brain. The article also explores the current RCT evidence in detail, but this is explored more extensively and systematically in the systematic review. Which takes us very nicely onto the second paper. This systematic review and meta-analysis has updated on the previous reviews and expanded on it by comparing patient-centered surgical and biochemical outcomes between surgeries performed with or without tourniquets. So this is an overview of the methodology used in the paper. So the authors adhered to PRISMA guidelines, and they performed a comprehensive database search, including multiple databases from up to October 2020. This was supplemented by manual searches of bibliographies of the selected articles to identify any additional studies. Only those RCTs were included that compared tourniquet used to no tourniquet, placebo, or alternative methods like tranexamic acid administration. Conference abstracts, animal studies, and non-English papers without accessible translations were excluded. Data extraction was done independently by two authors using standardized form, and the quality of studies was assessed using the Cochrane Risk of Bias Tool version 2. For statistical analysis, continuous outcomes were reported as mean differences and binary outcomes as risk ratios using the random effects meta-analysis with RevMan 5.3. Heterogeneity was assessed using the Higgins I-squared test, and for outcomes where statistical analysis wasn't feasible, they provided a narrative discussion instead. This study is the most comprehensive meta-analysis comparing lower limb fracture surgery with and without a tourniquet. However, the quality of evidence is notably low, with all randomized control trials judged as having a high risk of bias in at least two key areas, such as lacking blinding for patients and surgeons. Additionally, the sample sizes limit the strength of findings. Importantly, there's no statistically significant differences in postoperative pain, wound complications, or reoperation rates between the two groups. However, patients who had surgery without a tourniquet returned to full-time work quicker, which could have a meaningful implication. One notable result was that using a tourniquet reduced surgical time by about 6 minutes. This may reflect an improved surgical field of view. However, tourniquet use was associated with greater ankle swelling for up to 6 weeks postoperatively. Interestingly, even though patients who didn't have a tourniquet experienced less pain at the 24-hour mark, the result wasn't statistically significant. There were also no differences intraoperatively for blood loss between the two groups, which really challenges the perception that tourniquet significantly reduces blood loss during surgery. The analysis faced challenges due to variability in the studies. So, for instance, definitions for complications like non-union and wound infection varied, and restrictive criteria in some studies, such as excluding diabetics or heavy smokers, reduced the generalizability of the findings. Additionally, several important outcomes like cognitive function and biochemical markers were missing from the data, as were long-term patient-reported outcomes. These limitations underscore the need for a large multi-center trial to provide more definitive answers. In summary, while the use of a tourniquet does reduce the duration of surgery, this review did not find a statistically significant difference in postoperative pain, blood loss, function, length of stay, or complications between patients with or without using a tourniquet. Although clinically important differences cannot be ruled out due to small sample sizes and low complication rates, surgery without a tourniquet appears to avoid potential harms and remains a feasible option. It's important for patients to be fully informed about the potential benefits and risks of tourniquet use in their fracture fixation surgery. Both the editorial by Matt Costa and the systematic review have underscored a significant gap in high-quality RCTs on this topic. The current evidence is both limited and flawed, with most studies exhibiting a high risk of bias. A large pragmatic RCT is needed. This study should involve multiple centers and a diverse range of surgeons across the country. Ultimately, this research will help to establish a clearer understanding of the comparative benefits and risks of using a tourniquet in lower limb fracture surgery. Thank you for time and listening.
Thank you. Thank you very much for that presentation, Mr. Arshad. Could I invite Professor Matt Costa and Mr. Mohammad Farhan Alani? Yeah, they've joined the stage. And first of all, gentlemen, could I have your thoughts on this issue, and as well as your reflection on the preparation of these studies? Because this use of tourniquet and the discussion around it goes back to knee surgeons. I mean, my knee surgeon colleagues, you can split them down the middle as the group that swears by the tourniquet, the group that don't want to use a tourniquet. So was it something like that that stimulated you to look into this topic and take up these studies? Or are we trying to follow our knee surgeons?
I'll let you go first, Mike. Matt, sorry.
Well, the first thing, thank you, Nijil. Thank you for summarising the papers very nicely. Just to clarify, this is Mohammed's work. He was the first author on the annotation as well as the review. I was very much just a wingman myself, and Alex Trompeter were providing a bit of input from the Orthopaedic Trauma Society. So I'm very happy to defer to Mohammed on this. To answer your question, the prospect of splitting knee surgeons in half is slightly appealing, but it was nothing to do with knees really that changed my mind. It was, crikey, probably about 18 years ago now when I met a physiologist actually from Israel who was talking about tourniquets and came to sort of speak to me about when I used to work at Cobham Warwick. And he presented data about the effects of tourniquet from a vascular point of view, a vascular physiology point of view. And he showed some really interesting sort of Doppler images showing that when you release the tourniquet, you got this meteor shower of embolic something or other firing off into the blood system. And I presume that this was the vena cava, but he actually said, no, this is the carotid artery. And that slightly unnerved me. And he pointed out that when you release the tourniquet, because of the systemic inflammatory response from the release of the tourniquet and the ischemia, ischemic contents being released into the circulation, you get quite significant shunting through the circulation in the lungs. So actually, even relatively large emboli can bypass the pulmonary circulation completely, fire through the left side of your heart and straight up into your brain. So while I've been very happily blaming the anaesthetist for post-operative delirium in my patients where I'd used the tourniquet, it suddenly occurred to me that I may be at least in part responsible for this. So after that, I started applying the tourniquet but not inflating it. And I did this initially for all the cases below the knee, as many of us did, just by habit and by tradition, as you mentioned. And I realized that I was very seldom inflating it. In fact, I was never inflating it. So I stopped using it for simple injuries, ankles and so on. Foot fractures, I left it on for going around the back of the ankle or around the back of the knee. But then after about 3 or 4 years of doing that, I realized I'd never inflated that either. So over 10 years ago now, I stopped using a tourniquet full stop for all trauma, upper limb, lower limb. And quite frankly, my life's been a better place for that because I don't have the patients in pain and recovery. I know what the data says, but I certainly experienced that quite a lot. And the blood loss issue, I think, is a red herring. In fact, I'm much more comfortable stopping the bleeding on the way in than now I'm worrying about where the blood goes after I release the tourniquet at the end of the procedure. So that's my story. It's anecdotal, so I will defer to Mohammed for some science.
Thanks, Matt, and thank you for having me this evening. And thanks also to Faizan. I hope that message gets to you. You're probably not here this evening, but I hope that message gets to you. In response to your question, Nijil, I think it's very interesting because the use of a tourniquet, you were talking about total knee replacement surgery, it's very different. The indications why surgeons use a tourniquet in that operation is slightly different to why surgeons use it in ankle fractures. So one of the main reasons why, arthroplasty surgeons use it is to improve the quality of the bone cement interface and try and reduce the risk of aseptic loosening. But also they do say, you get a better view, and they say, you reduce bleeding intraoperatively and you can do the surgery quicker. But, there's been a Cochrane review recently that's come out about tourniquet use and total knee replacement, and we've seen that, the risks of using a tourniquet are present. You've got increased risk of pain, you've got increased risk of infection, you've also got an increased risk of blood clots. Now, whether that you can translate that those results to trauma, we don't know yet, because the studies that have been performed, as Faizan had presented about, they're quite limited in a number of ways. The quality is limited, the number of studies we've got is also limited, and frankly, there's just not enough data there to try and guide us to know whether we should be using these tourniquets or not in ankle fracture patients. One of the main concerns, I think, with using a tourniquet in ankle fractures, or in trauma anyway, is that you've got that second hit, or hypothetical second hit. You've got already traumatized tissue, and then you're using a tourniquet, and you've got a environment now in the ankle where you've got low oxygen, and when you release the tourniquet, you've got the post-tourniquet syndrome, you've got the inflammatory markers being released that Matt was talking about, and from the traumatized tissues, and you've got the reactive oxygen species, and whether that has an effect on the traumatized tissues and increases risk of the infection, we don't really know. And obviously, infection is such a devastating complication that even one event can be considered a never event, and if it's preventable from not using a tourniquet. And so we need more data really to try and guide us about whether we should be using these devices or not. And we don't have the data, and people are using them without knowing if they're safe or not. So my PhD is actually focusing on tourniquet use, and we're doing a number of studies, one of which is a feasibility trial, trying to see whether it's possible to do a large-scale trial in the future, comparing the benefits and the risks of tourniquet use in ankle fractures. And hopefully that will give us a better idea and a better picture of whether we should be using these devices. In the background recently, in the past couple of years, since I've published that systematic review, there have been a couple of studies, but only observational studies, and they've looked at complications. Obviously, because they're observational, they've got the limitations associated with them, confounding by indication and a number of other issues. But surprisingly, neither of them have yet shown there's any statistically significant difference in major complications and infection reoperation between patients who have surgery with a tourniquet and without tourniquet. In fact, I think it was last month, there was an article that was published in the BJJ that was looking at comparing major complications between the two groups, and that was a Danish fracture registry study. So that was quite interesting. And then there's the other study as well that was done by Heather Valier in the States, and she and her team had looked at the same issue, and they looked at patients who may have been even higher risk. They looked at diabetic patients, and they looked at smokers, and they did a subgroup analysis. And interestingly, they also found no difference in those subpopulations. But I think the question's still out there, and I think there is merit to trying to do a big trial to get the answer for this research question. And I hope my PhD study shows that it is feasible, and that we'll be able to do that in the future.
Yeah, good. Another point. Obviously, you started off with a large number of studies and narrowed down to choose just 6. I mean, you mentioned about the use of sham tourniquet and the use of other agents like tranexamic acid. Did you come across any interesting comparisons, using tranexamic acid on one arm and to control bleeding, and tourniquet on the other arm?
Interestingly, the only studies we found were the randomized. I mean, we only focused on randomized controlled trials, and we only found those 6, and they all compared surgery with a tourniquet to without a tourniquet. And we don't know whether some of these studies have been published quite a while back. They dated, I think, from 1990, and the most recent study was done in 2017. So, in most of these studies, TXA was probably not used then in ankle fractures anyway.
And another interesting point, I mean, I've seen foot and ankle surgeons now move to using calf tourniquets. So were there any papers, looking, what are your thoughts on that? Calf tourniquet versus a thigh tourniquet, does that make any difference at all?
To be honest, I'm not very sure, because I don't think we've got the data yet to be able to know whether that would make a difference or not. Yeah, I think the question's still out there. I've not got particular thoughts on that, but Matt Costa might.
Well, I'm not aware of any major evidence either way, Nijil, in that. To be honest, I stopped reading the literature. That's why I was very pleased to see Mohammed's review and his annotation, because since I gave up using a tourniquet, I sleep better at night, and that's just as important as the evidence to my mind. So given that I'd already given up on it, whether it was on the calf or on the thigh, I wasn't too worried about that. I just don't use them anymore. I don't see the point. But I totally take Mohammed's point that actually if the rest of the community, whether it's foot and ankle surgeons, trauma surgeons, or anyone else, are still using tourniquets, maybe we should do the trial just to prove it one way or the other. I think, as Mohammed said, the evidence contained in his review is necessarily limited by the quality of the primary trials, which is not great, and a lot of them are out of date in terms of current practice, including things like TXA, as you mentioned. So I think the jury's still out in terms of the evidence, but for me, I stopped using tourniquets a long time ago, and I'd struggle to be persuaded to put one back on these days.
And is that for elective surgery as well, Matt, or just trauma? You do only trauma, is it correct?
Yeah, sorry, Nijil, I've let you down. I just do trauma these days, but I think a lot of my colleagues, certainly in Oxford, have stopped using tourniquets for knees and ankles and things as well. I mean, some still do, but I think when you ask them closely, and Mohammed alluded to this, and so did you in your introduction, that a lot of this is tradition and what we were taught, and none of us have really made an active decision to use one or not use one. It's just that's what we did, and therefore, why wouldn't we carry on? But if you think about it, it doesn't really make a huge amount of sense, because where are the big scary blood vessels? Well, they're around the shoulder and around the hip. We don't use the tourniquet there, do we? And we operate quite happily. So why do we put them on with the little tiny vessels around the ankle and the wrist? It makes little sense to me, to be honest.
And another practical point, I mean, this is open to both of you. Is there any standardization or any rule around the pressures? Because, I mean, in your annotation, you mentioned that OTS surgeons use anything between 200 to 350 mils of mercury pressures. What is your advice on that, or any thoughts on that? Has any of these papers looked at any rule of thumb to what pressure it goes up?
It was reported in the paper. Interestingly, the pressures used are probably much higher than the pressures used in those trials are probably higher than the pressures that are currently used nowadays. I do remember, just from recall, one of the trials I think had set the pressure to something like 350 or 400 millimeters of mercury, which is pretty excessive, considering systolic blood pressure is probably about 100 intraoperatively anyway. So why you'd need to go up to that amount, I don't know. Recently, both guidelines have been published on the topic. Off the top of my head, I can't remember. I think it's 100 millimeters of mercury above systolic blood pressure is the recommended for if you're going to use a tourniquet, is the recommended pressure to use. I think it's interesting as well. It's interesting as well that most of when you think about the benefits and the risks of a tourniquet, the outcomes are very skewed. So the benefits are all kind of in favor of the surgeon. You've got, the theoretical benefit of reduced bleeding to allow the surgeon to see the structures in the operative field more clearly, and you've got a reduced reduced operative time. So all the potential benefits are in favor of the surgeon, and frankly, unfortunately, all the risks are then borne by the patient. And having interviewed and done focus groups with patients now and spoken to them about their experience of their recovery, most of them tell me that none of them were actually made aware of whether a tourniquet was used or not during the surgery. So it's quite interesting.
Thank you.
Just one other point, Nijil. Those of you who operate regularly under local anaesthetic will recognise the problems that the tourniquet causes. I appreciate that Mohammed's review didn't show a huge amount of difference in post-operative pain, but certainly the pain you get from the tourniquet massively outweighs the pain you get from the surgical site. And I remember back in the bad old days of doing carpal tunnels with tourniquets on when I was a trainee, and I got quick at carpal tunnels, and that wasn't because I was a good surgeon, it was because the patients were screaming in agony from the tourniquet after 10 minutes of having it on. So the idea that tourniquets don't create a huge amount of pain, whatever pressure you use, I think is probably not true. So I'm another reason for trying to get rid of them.
Yeah, true.
You may have detected I'm a little bit opinionated on this topic.
No, you're right. I mean, and again, a lot of our foot surgeon colleagues are going towards regional blocks and local anesthetic, especially for forefoot surgery. And we're trying to copy a balance from our hand surgeon colleagues, bring them into at least into a forefoot surgical practice. Right. We may have a few senior fellows on the audience. Any advice to them tomorrow morning? Do they go and win their tourniquet or continue what they're doing till a big RCT comes out?
I think from what I did, and you can take or leave this, is if you are a tourniquet user, if you believe in them, try putting them on but not inflating them, and just see how you get on. Because you can always put it on later. Just elevate the arm, exsanguinate it however you like, and carry on. And then just see how often you end up inflating it. Because that's what I did. And I, after a while, realised I just wasn't bothering inflating it. The other final point is, and Mohammed's review wasn't able to look at this because there's little cost effectiveness data, but a lot of units are now using single-use tourniquets, and they're pretty expensive. You tot up the amount of money you're spending by just applying this thing and throwing it away, then it's not without cost for the NHS as well. So I think we shouldn't forget the cost implications of using a tourniquet.
Great. Matt and Mohammed, thank you very much for a nice evening, passing on your experience both in your practice, from your practice and from the study. I'm sure we have got a few take-home points from that. Thank you again. And to everyone, there is a link in the message box, the chat box, to provide feedback, and you can get your certificates once you give your feedback. You would have noticed that James has come on. That means it's time for dinner. So, James, your final words.
Well, thank you very much. It seems I am indeed the prophet of doom. Gentlemen, thank you for your lovely academic menage a trois, which I have very much enjoyed. It's now time to wrap up this session. I'd remind you all that BOFAS is only 4 months away, the Golden BOFAS for Brighton, which promises to be a great meeting. I note the dinner is to be held in the Brighton Pavilion, and I'm told by Joe Millard that sedan chairs will be provided for those wishing to wear Regency costume, so we don't have to get our silk stockings wet. Early bird registration is open, so please feel free to join. Thank you to all of our speakers tonight, to Alex Beer, to Faizan Arshad, to our senior authors, Mohammed Farhan Alani, Matt Costa, Chris Bretherton, of course, to my excellent colleague, Nijil Vasukutty, who manages to put up with my poor organisation of this time and time again, and to Karam Al-Hotra for keeping everything going. The next Journal Club will be in 2 months' time. The details will be on the BOFAS website. The link is already there, so you can sort out your attendance certificates. And thank you very much all for attending. Thank you to those who have contributed, and I wish you all a good night.